Welcome. All right. Welcome, everybody. Welcome to this afternoon's BC Echo for Post-COVID-19 recovery session. My name is Johnny Chang. I'm a family doctor and hospitalist at Mount St. Joe's Hospital, and I have a private practice in Krishnan, BC. And today I have the privilege of being your moderator. As we are coming from various parts of the province today, we operate under the unceded and traditional and ancestral lands of many Indigenous peoples. We wish to acknowledge with respect and gratitude all of the Indigenous nations, Inuit and Métis communities with whom we live, work, and provide care. Project ECHO is a virtual learning community for specialists and community health care providers, where we use a combination of didactic and case-based learning to help improve care for patients recovering from ongoing symptoms of COVID-19. Without further ado, it is my pleasure to introduce Dr. Krishnan Ramanathan. Dr. Krishnan Ramanathan graduated from the University of Otago Medical School in Dunedin, New Zealand. He completed internal medicine and cardiology training in Auckland, New Zealand, before coming to do additional training and work in North America. He is currently the medical director of the Cardiac Intensive Care Unit at St. Paul's Hospital and is a clinical professor at the University of British Columbia. Since coming to British Columbia, he has been active in research to better understand the complex interplay between atherosclerotic cardiovascular disease, diabetes mellitus, and renal vascular disease through international multi-center clinical trials and local research. He is also a leader in ethnicity research, trying to understand the determinants for the increased incidence of atherosclerosis among South Asians. He is also the cardiologist designated to the VCH COVID-19 follow-up clinic. He was the inaugural recipient of the St. Paul's Hospital Foundation Physician Scholar Award and a co-applicant on a number of national grants. His publications are numerous, and he is actively involved in all levels of knowledge translation. He has received countless teaching awards, including the 2022 UBC Department of Medicine Master Teaching Award. He has led multiple provincial guidelines and participates in multiple provincial and national communities. I want to let everyone know that this session is fully accredited, so you will receive one main CRO credit or one MOC group learning credit for attending. We ask that you enter your full name and email address in the chat box. Certificates will be sent after the session. And without further ado, I'll pass this on to Dr. Ramanathan.
Thank you, Dr. Chang, and I hope you can hear me clearly. Thank you for asking me to come and talk to this illustrious group and a successful organization, and it is my pleasure to be talking to you today. The topic today is Post-COVID-19 or SARS-CoV-2, a cardiology perspective. These are my conflict of interest, and you can see they're mainly with industry companies in terms of honorarium and advisory, but all my research is actually peer-reviewed, funded, and has nothing of conflict today. I guess my main conflict is, as you said, I work with post-COVID-19 clinic, both here at St. Paul's and at Vancouver General Hospital. The objective of today's session will be to understand the cardiac manifestations of post-COVID-19. You will be able to apply this knowledge into your clinical practice, and you will then better understand how to assess, treat, and advise patients with cardiac conditions post-COVID-19. As a result, you will be able to understand the resources that are available and how to utilize these to optimize patient outcomes. So as a beginning, as a mankind, we have been used to different types of pandemics. The one in the yellow here is the bubonic plague, which killed about 200 million people. Then we have the smallpox, and then we have over here the Spanish flu, which is about 45 to 50 million people died. And now the COVID-19, the last estimate from the WHO was that probably at least 15 million people died throughout the world as a result of COVID-19 infection. Of course, as you all know, the accurate number keeping has been somewhat challenging because of different healthcare practices in different parts of the world. We all understand what the molecular structure of the COVID virus is. It has an outside spike protein. It has a membrane protein. It has an envelope. And in the inside, it has an RNA material in its nucleus. And you can develop antibodies to each one of these. We think that the COVID virus or SARS-CoV-2 originated from the bat, and then there was a mutation, and this led to it going to an unknown mammal. And there is a lot of speculation about what this mammal may have been in the Wuhan, sort of the markets. And then from there, it jumped on to humans. Again, probably there was a mutation involved. And this has been the pattern with many of the, especially the SARS-CoV viruses and many of the pandemics. And from human to human, we now also have mutations which are affecting transmission. As you probably know, at the early onset of COVID infection, we knew that the ACE2 gene played an integral part. So this ACE2 gene is where the spike protein is attached before it's enveloped into the nucleus, where its material can be then affect the replication, and then the virus can be replicated. However, before it can do that, it needs to be the spike proteins need to be activated by these serine protein that are also on the host cells. The cells that seem to have the highest concentration of the ACE2 gene is really the heart, the vascular, followed by the rest of the body. There are ACE2 receptors throughout the lung, kidneys, liver, the GI tract. So it can affect multiple organs, but the density is highest in the heart and also in the vasculature, also in the lung epithelium, hence where the predominant symptoms appear to be. The density also probably gives us some explanation to why there are so few infections in young people, because the levels of ACE2 receptors goes up with age, so that young people often have lower levels of ACE2 receptors, and they also have low levels of ACE receptors in their nasal mucosa, so they were less likely to be infected by the SARS-CoV-2 virus, as this is a respiratory pathogen. Once it takes hold of you, you initially have a flu-like symptom, then it's usually localized to the lung, just because there are a lot of receptors in the respiratory epithelium. This leads to an immune system activation, and then as time goes along, you get a hyperinflammatory state or cytokine storm, and there's also a thrombotic stage. Earlier on, the viral replication is very high, and as time goes along, viral replication becomes low towards the end of this cascade here. So you can see there are a lot of things that are going on: cytokines, prothrombotic, and immune responses, all of which lead to the contribution of the syndromes we see. If we were to focus now primarily on the heart, so we can see there is a variety of mechanisms. So there is a direct effect on the heart, on the microvessels, which can lead to hypercoagulability and probably pulmonary emboli. There's also involvement at the coronary artery level, which leads to endothelial dysfunction and acute coronary syndrome. There is also viral inflammation that occurs, or inflammatory markers because of lung involvement, which form inflammation, and cytokines, which can also affect coronary arteries. And then the involvement of the myocardium itself can lead the myocardium to render it irritable, to have arrhythmias, or if there's significant myocardium involved, it leads to heart failure. So we see that the common things that we see acute coronary syndrome, possibly there's plaque rupture involved, there's heart failure, arrhythmia, and pulmonary embolism. So multiple cardiovascular effects that are going on. There were a lot of information about biomarkers, and this graph on the left here shows you the red, the biomarkers of the non-survivors, and on the blue, biomarkers of troponin of survivors. You can see non-survivors immediately had a much higher level compared to those who are survivors. And the cause of the troponin can either be ischemic cause or a non-ischemic cause. And we also understood that there were people who have chronic cardiac troponin elevation, and especially these tended to be pre-existing people with cardiovascular disease. If we look at it on a scale, generally the patients who had myocarditis or Takotsubo or cardiogenic shock had very extreme high levels of troponin, either T or I, and those who had heart failure, pulmonary embolus, or ARDS tended to have sort of moderate level of troponin, especially with or without pre-existing disease. And those with chronic diseases and pre-existing cardiac diseases tended to have higher troponin than those who are healthy with no pre-existing disease. So you can see why the troponin was a predictable marker of what might come in terms of outcome following this infection. And that is better depicted on this slide. On the red line, this is all-cause mortality. Those who had myocardial injury on the left, on the red, and those who did not have myocardial injury in the blue. And in the panel below, you can look at it in terms of those who had wall motion abnormality or evidence of significant myocardial involvement versus those who did not have myocardial involvement. So again, that stratified patients. This is a large database taken out of New York where they stratified people by levels of troponin. Those who had very low levels of troponin, those who had intermediate levels of troponin, and in the red, those who had the highest level of troponin. And you can see over time in these hospitalized patients, this predicted what your outcome was likely to be. And we also know from other information or other data that people with pre-existing cardiovascular conditions, such as diabetes or cardiovascular disease, tended to have higher levels of troponin, and higher levels of troponin tended to have a worse outcome. There are other biomarkers that were studied, ANP and BNP, and these were also elevated in significant number of patients, especially in the acute phase of the illness, and not really playing a significant role in the chronic phase. So if we were to summarize this portion of the talk, we would say that the ACE2 receptor is what we will call as the gateway receptor. This is how the COVID-19 virus enters. And especially in the throughout the body, there's an immune system that's involved, there's a hyperinflammatory process, prothrombotic, and cytokine storm. And the degree of which these things occur relates to your clinical manifestation. And as a result, there is a variety of effects on the cardiovascular system, and we will look at some of these in specific cases coming up. Biomarkers play an important role in the acute phase, and they don't seem to play an important role in the chronic phase or the phase that we have now known as long COVID. So troponin especially is a predictor of poor outcome. Elevated troponin is a marker of poor outcome. This is a patient that is a 64-year-old female with hypertension, dyslipidemia, presented with two-day history of chest pain, not known to have COVID, and there's no dyspnea, cough, fever, or chills, or diarrhea, recent travel, or sick contact. But however, the patient later on did test positive for COVID. Although the patient was hemodynamically stable and their oxygen requirement was actually very minimal on arrival, things changed. And you can see on the electrocardiograph, there is actually ST elevation in leads 1, AVL, and from V2 to about V6. So this was a pattern that we were not familiar with before. This would be synonymous with somebody who's having an acute myocardial infarction. But when we took this patient to the cardiac catheterization laboratory, this is the left anterior descending artery, and this is the left circumflex artery, and this is the right coronary artery, there is in fact no significant obstruction to explain for the findings. So often patients with COVID-19 infection presented with ST elevation pattern on the electrocardiogram, which one might say then later on evolves to suggest a myopericarditis pattern. This person had initially a normal left ventricular function, but it deteriorated very quickly. They had a wedge pressure of 21, suggesting they were in pulmonary edema, and their cardiac output when assessed was very low at 1 liter per minute per meter squared. And this is about 5 times less than what it would be in a normal individual, and therefore they needed treatment with inotropes. This is another case that we were involved with. This is somebody who had a non-ischemic cardiomyopathy with recent normalization of their left ventricular ejection fraction. They had history of atrial fibrillation, hypertension, and diabetes. They presented with a non-productive cough and shortness of breath for 2 days. They were hemodynamically stable, but they were requiring some oxygen. And with oxygen saturation, they were able to maintain a saturation of 88% on room air. You can see radiologically there's bibasilar sort of opacification. This is very common. It's very difficult to see the left diaphragm, suggesting there may be a pleural effusion there. And there's in fact also a pleural effusion on the right side. On the electrocardiogram, we don't actually see much. The patient is in sinus rhythm with PVCs, and they're sort of non-specific T-wave abnormalities. This degree of T-wave abnormalities would not be associated with somebody like this. So this is probably not related to what's going on. The patient had some mild kidney dysfunction, elevated liver function enzymes. Their troponin was elevated, but more importantly, their BNP was vastly increased. So this person was having pneumonia plus heart failure in conjunction with their COVID-19 infection, and their ejection fraction was 30%. And this person actually, you can see when they were treated for the cardiogenic shock that they were in, they developed ventricular arrhythmia. So it's an irritable heart, and with inotropes, it was getting more irritable. The next case is one that was very interesting for me and initially very puzzling. And this was a 17-year-old Japanese student who was studying at UBC. And he had multiple visits to the emergency department, mainly with fever. He was diagnosed with, first of all, a strep throat, then possible infectious mononucleosis. But when we saw him, he had predominantly sort of GI symptoms, which was very unusual for the standard COVID patient. He had this very unusual looking type of rash. This is not the patient itself. He had marked conjunctivitis and an abnormal sort of dry, cracking tongue and lip. And this is what we've subsequently understand as multi-system inflammatory syndrome. This is most commonly seen in young patients, usually less than 10 years of age. It's often known as MIS-C, but this was a MIS-A because this was actually not a child, but an adult. So the constitution of symptoms here is very different. You have neurological signs. You have severe impairment of left ventricular function. You have coronary dilatation. You have a predominance of GI symptoms, diarrhea, nausea, and lymphadenopathy. So it mimics maybe a number of other conditions like adenovirus infection. It could be an autoimmune or autoinflammatory disorder. And given this patient was Japanese, it could have also been a Kawasaki disease. But it's unusual to see low ejection fraction in patients with Kawasaki disease. And he also had dilated arteries. And he was treated with immunoglobulins, and dramatically within 5 days of immunoglobulins, he improved and his ejection fraction returned to normal level. And when we re-imaged his coronary arteries, these had actually gone back to their normal appearance. So a very unusual presentation known as MIS-C, whereas the other ones that we talked about was some of the more common presentations. The one that we often always talk about is, myocarditis, and this is actually quite, it's more controversial than what you might believe. We know that viral pathogens can cause inflammatory lesions, and we will look at some of the mechanisms. And we know that the SARS-CoV-1 and the MERS-CoV-1 viruses all also cause myocardial involvement. But the COVID-19 was slightly different. There was a high variability in the reporting of myocarditis. Initially, some people said it was up to 60%, but when we started to look at biopsies and other things, the incidence was actually much lower. There was evidence of cardiac injury in 1 in 5 patients, and these patients had increased mortality, as we have shown, as I showed you earlier, and they were more likely to have lasting effects. In terms of what is the direct effect that COVID-19 has on the heart, it can be either a viral infection or a systemic inflammation and thrombosis. Manifestations of COVID pathology observed in biopsy patients include microvascular thrombi, ischemic injury, right ventricular strain pattern, pericarditis, myocardial inflammatory cellular infiltrates, and full myocarditis with myocyte destruction. So you can see there's a variety of things that go on as a result of COVID, all resulting with elevated troponin, but they may not be directly due to myocarditis. While COVID-19 associated heart failure could be attributed to viral myocarditis, it is postulated that the systemic inflammation, which originates from the lung or blood vessels, cause the majority of myocardial injury. So it is possible that the injury that we see, or the significant LV dysfunction that we see, or myocarditis with substantial elevation in troponin, is really a bystander response to what's going on in other parts of the body. In terms of the immune activation, we know this is the endothelial cells where the virus is uptake, infects the endothelial cells. And then we have activation of macrophages. There is increase in certain markers indicating that macrophage as a potential driver of this disease, especially in cardiac myocytes. This then leads to the cytokine storm, where there's decreased CD4 and CD6, and other pro-inflammatory markers are increased, and this can also lead to inflammation. These can also trigger other inflammatory pathways with IL-6 and IL-1, and this can lead to what these things are called NETs. These are really fibrin deposition products within the vasculature, and that itself can cause inflammation. So you can see there is a lot of complex things going on, and it's not really, it's much more than simply the virus affecting the myocyte per se. There is a lot of work that is ongoing with trying to understand myocarditis, including understanding the current mechanism, the plausible pathologies that are involved, what are the different contributing factors, and also trying to understand what the long-term cardiovascular effect is. At least in COVID, we have also described myocarditis secondary to the vaccine, and this has a very different profile as opposed to the reported myocarditis with the COVID virus itself. It may be a production of pro-inflammatory cytokines, that you have a robust immune response. It may be related to the vaccine dose and the amount of mRNA vaccine that you receive. Certainly the rates are much, much lower. This has been observed mainly with the mRNA vaccines, about 10-fold less than with myocarditis. And there's a significant sex difference with much higher in young males. And it's thought that testosterone increases viral replication and inflammation, whereas estrogen has a cardioprotective effect. Generally occurring in the first 1 to 2 weeks following in most of the patients in young males, 1 to 2 weeks after a Moderna injection. I have not entered in here the complication that we saw with the AstraZeneca vaccine, which was thrombosis, as that vaccine has been taken off the market. So when we think about at least myocarditis, in this setting, we have really the spike proteins. We don't have the internal proteins. So this is what's called spike protein molecular mimicry. This creates a type 1 inflammatory response, and that causes myocarditis with symptoms that are very similar to what we might expect with COVID. So we know that there are viral myocarditis with inflammatory infiltrates consisting of mostly T cells and macrophages, whereas in the COVID, we have an overactive immune response integrated with a coagulation system, activation, and this coagulation tends to be the main driving force. Significant higher CD4 to C8 ratio, classical, similar to what we see with other viruses, but there's excessive neutrophil activation, platelet aggregation, and thrombi are present compared to the standard viral myocarditis. When we look at the mRNA, this is a completely different mechanism that's going on and very different to the myocarditis associated with COVID and also myocarditis associated with other viruses. So for the second portion of the talk, we have a spectrum of cardiovascular disease with COVID. Myocarditis is generally uncommon as a result of direct myocardial injury and probably involves multiple mechanisms, which it's hard to tease out in the individual. Although the vaccines have been very effective in decreasing transmission and also decreasing the severity of illness, they themselves can cause myocarditis. And there is ongoing research that is occurring in this field to help us understand all this. The next portion relates to more of the chronic phase of COVID-19. So we know in Canada, at least 3.9 million people have tested positive, and this is an underestimate. And the mortality rate in Canada is 1.1%. If you have people who have an acute illness and who many of them will recover, but some will have ongoing symptoms beyond 4 weeks. And this is what is now known as long COVID. And these patients have a myriad of symptoms that they present with: fatigue, headache, shortness of breath. And I'll show you that they have many more symptoms as outlined in this newspaper article. This is what we call a heat map. And this is looking at a web-based study of over 3,700 patients. And they asked patients to list all the symptoms that they had and looked at the times which they were occurring in relationship to the infection. I've highlighted to you the 7 cardiovascular symptoms. In blue are all the cardiovascular symptoms that people would have reported. And you can see there's a huge heterogeneity. Some people have certain types of symptoms which occur early, but then don't occur. Other people have different types of symptoms that are predominant at the start, but then they go away. So there appears to be no pattern to say that one particular symptom predominates earlier on and then disappears, or there are also occurrence of symptoms that occur later on. On this heat map, we look at the severity of the symptoms. This is week 1, no data, symptoms absent. In blue is temporary break in symptoms and symptoms present. And you can see again, there is a great degree of variability. Symptoms seem to come and go, and there appears to be no pattern. So it makes it very difficult for us as clinicians to understand, as this is very different to many of the common conditions that we're used to treating. So there is no pattern in terms of what the symptoms are. They can occur early and late, and their severity also changes with time. It's also very hard to understand these patients' symptoms, especially if they've had other hospital events that occurred. If they had a pulmonary emboli, did they have post-critical illness syndrome? Did they have other problems during their illness that may have contributed to it? There is also multi-system inflammatory disorders, and they have GBS also. These have all been described in these patients. So sometimes when we see these patients, it's hard to know whether everything that they're experiencing is directly related to COVID, or is it a consequence of other things that happened as COVID, or is it related to a hospital illness, or is it due to a pre-existing problem? What we have come to understand is there are some risk factors that have been identified as those patients who are likely to develop long COVID. If your viral load was initially very high, if you have presence of antibodies, other autoantibodies such as to SLE and rheumatoid arthritis, if this is a reactivation, your Epstein-Barr virus, if you're a diabetic, you're more likely to have long COVID. Tends to be more common in the elderly, more common in the elderly also, but also has a predominance towards more females having long COVID. Also, there is some research showing that it may be more common, but the evidence for this is not strong that it's related to hospital illness. If anything, most of the research would suggest that it's not associated with the severity of hospital illness. Long COVID, it leads to functional impairment, neuropsychological symptoms. There are situational overlay, financial problems. So remembering what went on in the pandemic, people, not only their health was affected, their work was affected, and their social support system was affected. So we were left with people who had a significant debilitating problem that was often very difficult to diagnose. Nobody had a specific test. Nobody knew what the terminology was or what to do, and the patients had lost all their support networks that they had. In addition to this, we also notice as patients have what's called this push and crash cycle. They notice that there would be some days that they would be better, other days they would be worse. If they tried to push themselves, then they may be able to do it one day, but then they would crash the following day. So they were following this sort of the cycle here with overexertion, increased symptoms that lead to rest, then reduced symptoms, frustration. So they were in this cycle. So we had to find ways to try to break this cycle. The brain fog or subjective cognitive impairment was also very common. And this required sort of a multidisciplinary approach to try and understand. In some people, the trigger was fatigue. Some people was mental stress. In some people was exercise. Some people was nutritional problems. So we had to try to find what might be the trigger for people having subjective cognitive impairment and to try to help them with these patients. And you can see that, we as clinicians were also learning about this as we were going along, and we were also learning from the patients. So this is where the COVID-19 clinic became very helpful. It was really learning from the patients to try to help patients. What we did learn over time was that if we had an unhappy patient and we wanted to be a happy patient, we needed a full support of patients to help us. So if we wanted to return survivors to health, it had to be a multidisciplinary approach. We needed physiatry, we needed allied health, we needed neurologists, we needed cardiologists, we needed general internal medicine physicians. So so this was a very complex situation that required an interdisciplinary approach. And I think our COVID-19 or post-COVID-19 clinics were able to provide this for patients. And most of the patients seemed to benefit from the structure that was developed as a consequence of identifying this entity. So we also realized that one size did not fit all, and that we needed to personalize the treatment. So we needed to take an approach to what was their social support, what was their work support that was required, and they required frequent assessment and reassessment to make sure they were on track. So we all had to upskill ourselves to how to treat these patients because none of us had really had a lot of experience, and we were learning as we were going along. So we all thoroughly enjoyed this process, and we called it learning from patients to trying to help patients. I'm going to share with you now some data from our COVID clinics. So these were patients who either referred or could voluntarily come. Some you could see were hospitalized and some not hospitalized. Generally speaking, hospitalized patients were older, remembering that these were the patients who are likely to have more comorbidities. And you can see a pattern that we saw with other countries or other areas. Asians tended to predominate. So this is probably reflecting socioeconomic status, and which we also saw in other areas of the world. This is patients who complained of symptoms at 3 months, and they've been stratified by age. Those in the youngest age group, less than 45, with yellow, blue, 45 to 59, and red over the age of 60. And you can see that there was a predominance of mainly young people complaining of most of the symptoms, majority of the symptoms. Shortness of breath, very high. Chest pain, palpitations. These are common cardiac symptoms that they would have. And you can see this was high, especially in their young age, where we would think that the likelihood of having disease is probably low, whereas the elderly patients, where the likelihood of having underlying disease is much higher. This is again the same sort of information divided by males shown in blue and females shown in the sort of the mustard color. Overall, across the board, the symptoms tended to be more reported by females than by males, even though we had roughly similar number of both males and females. When we looked at the same sort of thing by hospitalization versus non-hospitalized patients, predominantly the symptoms seem to come from non-hospitalized patients. And this may be a reflection of the survival bias. The patients who were severely sick and hospitalized were happy just to go home and to be recovering. They were thankful that they had recovered from the COVID, whereas those patients who were probably not admitted were wondering, well, I didn't have things bad enough. Why am I feeling the symptoms? So they were probably reporting their symptoms more. In terms of activity, you can see again stratified by age. There's no clear winner here. Depending on different activity, different age categories reported them. So to summarize this portion, chronic phase or long COVID, now we have some idea of what are the risk factors involved. This is those patients who have symptoms for more than 4 weeks. Unfortunately, we don't have any specific tests, but our understanding is growing. And I think the COVID clinic at both St. Paul's, Vancouver, and other parts of Vancouver and British Columbia have been helpful. What we have learned, one main lesson that we learned, is that multidisciplinary approach is needed to address these patients, as they have a complex set of symptoms and interplay with their physiology. Now turning specifically to sort of where my sort of patients came from. So we asked patients to refer to a cardiac specialist if there were issues about chest pain that needed clarification, if there was issues with shortness of breath, frequent palpitations, or orthostatic or lightheadedness. And so these patients were referred to us for further evaluation. And these are the patients that you might see in your practices or in primary care. I think when we're thinking about chest pain, what we want to do is to make sure it's not ischemic. And this again will depend on what the pre-existing conditions are, risk factors. We want to know if there's new ischemia versus existing ischemia. Anybody who has underlying pre-existing disease, I would have a low threshold for investigating these patients. The ACS, if you suspect somebody has ACS, we don't encourage you to order a troponin, but to send you to a facility, acute management facility, because if this is sort of acute coronary syndrome, we want them to be evaluated there. We thought that the investigations could be functional versus imaging, and then the treatment is nothing different for these patients as it would be for the regular ACS patient. A lot of patients' chest pain may be due to myo or pericarditis. I think in this instance, ECG is very helpful, as well as the history, and the echocardiogram can also be done if somebody has persistent increase in troponin to make sure there's no inflammation or loss in cardiac function. And if we're suspecting inflammation, then cardiac MRI might be the best test. Treatment for these patients tended to be non-steroidal anti-inflammatories and colchicine. Thromboembolic disease, we would investigate. Again, thromboembolic disease, you would have to have a high clinical suspicion. Shortness of breath is a very common condition, common reported symptom, and it may be due to heart failure, so you would have to rule that out. You would have to think about thromboembolic disease, although this is very rare. In people who have underlying lung disease, this may be an exacerbation of this. If you have a residual lung disease from your hospitalization and you had severe pulmonary COVID involvement, you may be developing pulmonary hypertension. The other thing that was evident for us was we found, especially in hospitalized patients, that deconditioning also led to a significant number of patients complaining of shortness of breath, and they were mainly helped with rehabilitation. Palpitations, well, this is a very broad topic, and patients complain of palpitations or feeling of their heart racing. And this was also very common. This often required an ECG or a Holter monitor. And nowadays, many patients will wear wearables. And there are no specific treatment for these patients, and these generally improved over time. We did see that patients who had atrial fibrillation previously, just like with other conditions, you could, COVID infection could bring out atrial fibrillation and could also bring out or unmask ventricular tachycardia. Inappropriate sinus tachycardia, very few patients. Soon as they start to take more than 5 to 10 steps, their heart rate's 120, 130. They often respond well to beta blockers and ivabradine. And you can see in this schematic, there are acute problems and chronic problems in terms of arrhythmia. Postural orthostasis is also very common, and this is we saw this, and we looked at what was POTS-like syndrome, not POTS per se, but POTS-like. Again, this is a very difficult diagnosis to make, probably requires a specialist referral, and these are supportive treatments. And there is now, sometimes in very rare cases, we use metadrine, beta blockers, or ivabradine. I show you this slide because this was just published. It looked at people who did poorly following a COVID infection in these variety of countries. And you can see most of the people with pre-existing disease had cardiovascular disease, coronary artery disease, atrial fibrillation. Only very few had peripheral arterial disease. The most common risk factor was hypertension, followed by diabetes, and also obesity was the largest risk factor. If you look at the odds ratios here, the people, this is an association between heart disease and subtype of in-hospital mortality. If you had heart failure or NYHA functional class 3 or 4, that was the group that was likely to have the worst outcome. So people with pre-existing disease and who have maybe NYHA poor functional capacity are likely to do worse. This shows the different cardiovascular complications. Again, this is in the hospital, and you can see that in the critical care were most of the people who had PE, but everywhere else, the PE rates were very low, and other conditions rarely were involved. So specific symptoms for consideration. Pre-existing and genetic predisposition of disease is a key factor. Very few investigations have been helpful in the chronic phase, including echocardiogram, CT, and exercise tests, as well as biomarkers. I think the way that we balanced ourselves, what we now know is investigations are best guided on a base of good history and clinical acumen. Although patients may present with cardiovascular symptoms, this shows you the lung field of somebody with the control COVID, liver of somebody with control COVID. This shows you somebody with the kidneys by MRI control COVID, and this is the heart. So we still, although we think of things in isolation, there is actually a lot going on with these patients, and multiple systems are involved. If we look at their quality of life, and on this plot, you can see they scored very poorly on all these parameters. When patients who've had COVID, they have poor quality of life. There is likely to be significant impact on the healthcare system, especially the non-communicable disease management was disrupted, and this itself will lead to other issues as we've identified on this slide, and thanks to Dr. Jill Calder for providing me with this. And although this was our first sort of what people called it wave, we called it first system, then we have the second system, and eventually we have third, fourth, and the fifth system, which is affecting a variety of different healthcare systems and having different impacts, which then feed back on the patients who have COVID. Now, I won't spend too much on the variants, subvariants, and this is something that we can discuss. But I do want to highlight to you that when you're seeing these patients, you will often have questions. And I think there are substantial resources such as a race line, there's a cardiac race, there's a general internal medicine race, there's a respiratory race, and thrombosis race. So depending on what you think the patient's issues are, I would contact these people who probably will have also some experience in this and will give you guidance rather than having to divert patients to the hospital. So in conclusion, ACE2 receptor, over 15 million people have died. There's an acute phase with a variety of cardiovascular manifestations. Biomarkers are helpful. Myocarditis is something that's unique that we're learning to understand. It can result in a prolonged illness called long COVID. We don't have any specific tests. We don't have specific treatments, but multidisciplinary approach in trying to identify triggers and alleviating triggers have been helpful. Therapy guided by careful assessment is often required in a multidisciplinary approach and specialist clinic. The increasing impact on non-communicable diseases and overall healthcare and society is going to be huge. But I do want to thank all of you who've listened to me. I think one thing that COVID has shown is the resilience in the healthcare system in Canada. We were faced with a new entity. We all learned about it. We all learned how to cope with these patients. We all came to work to help these patients, and we learned from these patients, and now we're helping these patients. So to me, that speaks about a resilient healthcare system. So with that, I'd like to acknowledge these people, Dr. Jane McKay, who's been tremendous in providing me with support and providing some of the data I shared with you, Dr. Chang, who's a facilitator, Ravina for organizing this whole thing. I don't know how you do it, Ravina, and the other administrative assistants who are there. So thank you very much.
All right, thank you, Dr. Ramanathan. At this time, we can start with some questions, and I'm sure there are many. At the bottom of our screen, there's a raise hand function. And so if you do have a question, please use that. And remember, once we answer your questions, you can lower your hand. Before we get to that, I did see there was a question in the chat box. So just go back to that and I'll read it out. So 1 second here. So the question is from Jennifer Phillips. If troponin is a good predictive marker, why isn't that a criteria for Paxlovid?
Sorry, can you repeat that question, Dr. Chang?
Okay, so the question in the chat box from Jennifer Phillips was, if troponin is a good predictive marker, why isn't that a criteria for Paxlovid?
You know, I'm not sure if it's been studied in that situation. The people that we've studied have been in people mainly who've been hospitalized with it. So until we can understand better what the relationship between Paxlovid and troponin, we won't know. But it seems to, remember that the poor marker may be a manifestation of multiple things that are going on rather than one specific entity.
Okay, thank you. Okay, and okay, Dr. Uppal?
Can you hear me?
Yes.
Hi, yeah, I'm in the post-COVID triage clinic. So we do a lot of the initial assessments for patients. So a lot of the patients that, come in with chest pain, they've gone into emerge, having palpitations, having shortness of breath. So those patients are always very challenging in terms of what kind of education and support that you give them, because we don't always know their medical background in terms of what do you do every time that you're having chest pain and shortness of breath. We can kind of give them the rest symptoms, the other symptoms, but I always find it challenging being, having the cardiac background. How do we know these people aren't having more other extreme cardiac issues going on at the same time?
Right. So that's a good question. The main thing that we have found is that knowing what the history is, at some stage we have to make some assessment of them. So luckily for me, I see them once they've been seen by a few other people before, and probably most of the people who have symptoms that are not typical or are improving are not referred. But I think, without understanding what the person is, what their risk factors are, I think it's very hard to say, chest pain, everybody go to the emergency department, or chest pain, don't go to the emergency department. We have to have a system that helps to stratify patients. And one of the simple things is, often age is an important one, right? So often older people are more likely to have pre-existing disease versus younger person, someone in their 20s is probably unlikely to, unless if they've got a familial hypercholesterolemia type situation. So I think we need to probably understand patients to help us to triage who needs to go, to where, and who do we need to act upon early or not. One thing is if somebody is already on cardiac medication, you would probably have a lower threshold for sending them. If somebody's not on cardiac medication, then you may have a much higher threshold. So again, this comes down to some of our clinical judgment and how to use the resources that we have in a fiscally responsible way.
Thank you.
All right. And is there any other questions? All right. So I just again want to thank Dr. Ramanathan for giving this talk today. That was excellent. And I just want to remind everyone that we do have a post-event survey that will be sent out to all the participants of this session. Please ensure that you take 2 minutes to fill out this form. And finally, we have our last ECHO session, post-COVID-19, a respirology perspective, and that's going to be held on July 12th, on Tuesday, from 12 to 1. It will be by Dr. Shah, a respirologist at from Vancouver Coastal Health. So that's just a reminder. And again, thanks everyone for coming, and we really appreciate you taking the time for the session.
Thank you, Dr. Chang, for facilitating.